Welcome to WHIG-TV as we have a special interview here today with Dr. Lee Isley of Nash UNC Healthcare, and we're going to have a kind of a follow-up interview to one we had last year when we were introducing him to the community and kind of get a state of healthcare with our hospital and our community and talk about some of their plans for the future. Welcome to the station.
Thank you for having me back. It's good to be here with you today, Clint.
Lee, you've been with Nash UNC Healthcare now for about 15 months. Is that right?
That's correct. About 15 months, and so about 12 months from the last time you and I sat down.
Yep. And so during that time, there's been a lot of opportunity for you to observe, to bring in some more leadership and help you out in the running of the hospital. Kind of talk about what this last 15 months has been about for you.
Yeah, so we, in partnership with our board and our medical staff, have been looking at our operations where there's opportunities. We've been working with our community and engaging with our patients and with our stakeholders to find out the things that we're doing well, but also the things that we need to work on. And then over the last 6 to 8 months, we've taken some of that information and started talking about the future and what does the next 3 to 4 years look like and what do we need to achieve. We've been making some progress along the way. It's not as if we haven't been doing anything and then just said, well, we'll plan for the future. And so certainly have been making some headways. And really the strength of that has been the engagement of the board and the medical staff to come and engage in that conversation with us. And I'm excited today about being able to share some of those things that have been occurring out at the hospital.
And we're going to talk about a lot of subjects. We're going to talk about things such as, the ER wait times. We're going to talk about Leapfrog scores a little bit. We're also going to talk about your strategic plan and what some of the things you have in mind for improving everything for our health of our community, because as we said last time, the status of the hospital reflects the status of the community. The health care of the hospital reflects the health care of the community, whether it's financial or actually medical. And so, Nash UNC has an obligation in terms of serving our community as well as serving your patients. So let's kind of get into it a little bit here and talk about, your strategic plan. I know Jeffrey Batts, your chairman of the board, recently put a letter to the editor in the Telegram and talked about, the state of the hospital a little bit. But in your words, kind of talk about where you're going and what are some of your plans.
Sure. So after the three things that the board has asked us to continue to be focused on is patient experience, financial sustainability, and quality. And so really the three core measures of what every healthcare system should be striving to work with their community. And so we took that, we engaged an outside group to help us come in, take a look and engage us in those conversations on how we move forward. And we really took a 6 to 8 month process. We started in the October timeframe. Jeffrey put together a group of board, physician, and community representatives. We had a representative from the UNC health system to join in that conversation with us, and we called that the Oversight Committee. And they really evaluated, reviewed the information that came in, and helped guide the organization. And then through about 240 different interviews and interactions, both with faith leaders and community leaders to our medical staff, our department leaders, a picture started emerging of the things that we needed to work on as a health system. The Oversight Committee reviewed it in late April, early May, and made the recommendation to the full board, which they ratified in May. Dorsey Tobias is helping us roll that out and keeping the executive team and the medical staff focused. It's a 3-year plan, and so we have year 1 initiatives, and then those build on years 2 and 3.
All right. So, and one thing I do want to mention, because last year when we talked to you, you were also doing some job shadowing. You said you were kind of going once a week into some of the different departments and watching them. Did that play a part in some of the knowledge that you were obtaining for this?
Absolutely. And so I continue to go out once a month and work with the different departments and be able to see, as we talked about, the things that we unintentionally inhibit our staff and how they're doing a good job and how they're interacting with our patients. And so we've been able to see some of the things and made some changes. Food service, and even after we changed food service,
Right.
We had some more opportunities and went back and through shadowing and rounding, we were able to bring in iPad ordering system and some enhancements to make sure that we were meeting the needs of our patients.
Well, and I think that goes directly to the heart of what some people think about with hospitals. And you go in a hospital, it's a sterile environment. It's sterile sometimes is not always a good thing when you're thinking about the people and the heart of the matter. And, administrators and patients, the doctors who are providing care, sometimes those policy things and compliance and regulatory, those are just annoyances to just getting the job done.
Sure.
Balancing that, I'm sure, is a very difficult task to make sure you are putting the patient care first, but you've also got to follow some rules and some laws.
Well, as you know, we're heavily regulated, and we have to follow, ensure that we're providing a safe environment for our patients, and that we're meeting those regulatory requirements. But we also have to make sure it's a good environment for our staff and our medical staff to be able to practice medicine in.
All right. So let's get to some of the other things, Tom. And I do want to make sure our viewers know who you are a little bit. Again, it's been a year since we last talked to you, and we're not going to do a deep dive into your background like we did last year because hopefully they can still watch that. But, you're a guy who came from the paramedic realm. You're a guy who literally were saving people's lives with your hands in the field. You got an MBA and you came into the path with administration in the hospital. That's the quick route. But you're somebody who's been in the field. There's not too many people in the administration of hospitals in the country, let alone North Carolina, who kind of come with that experience. How does that frame your administration?
Well, certainly having a clinical background, I think, is a great asset. And so one of the things that, as I work with young hospital leaders, that I encourage them, if they don't have a hospital background or a clinical background, that they spend as much time in the field and get comfortable with those discussions. And so one of the things that it allows me is a small understanding as we sit with the physicians and the nurses about the things that they're concerned about, because I've been concerned with those same things and at least been elbow to elbow with them as we've been providing care. And so I try not to forget that, even if they think I do sometimes.
Wow.
And
you remember where you came from.
That's right. Try to balance that.
All right, so let's talk a little bit about some of the things. I know we've got some slides we're going to be sharing with the audience and so forth. One of the things I know that kind of is top on people's minds, and there's a lot, again, the ER times, we're going to get to that here in just a second, but the one, you see it in the media a little bit and stuff like that, who owns Nash UNC?
So Nash UNC is a community asset through the county. They authorized the establishment of an authority, hospital authority, and gave that authority the overall oversight and governance of the operations of the health system. And so it is the governance of this is a board of commissioners, 14 board of commissioners who all live and work here in our service area. Right. They're all individuals that everyone probably knows very well. And they have the fiduciary responsibility for the oversight and the assets of the health system. So it really is the community's health system, and the community has authorized that 14 board member group to oversee the operations.
So, I've had this conversation for 4 years now, I think we've had. UNC doesn't own Nash Healthcare?
So UNC does not. The assets...
I knew that before I asked you, but I want to make sure we're reinforcing that.
Sure. So UNC and Nash have a management arrangement. And so through that management arrangement, we're able to have access to some of the UNC resources and expertise, really, and avenues. So they neither one of us necessarily bring prescribed things to the table. They present some opportunities. The board has to review every one of those and approve those. And a great example of the assets that were brought to the table that improved Nash performance was our electronic medical record. And so through Epic, we were able to access that much cheaper and much easier because of our partnership with UNC, and we were actually able to implement it. I think we may have chatted about this. UNC had implemented this at 7 other hospitals prior to implementing it here. So
they worked out all the kinks over there before they brought it to us.
They really did. And I don't want to take away from what the medical staff and our staff did because there was lots of training to familiarize themselves with the electronic medical record. But the administrative portion of it, or rolling it out, we really had a playbook.
Right.
And we had the assets of UNC, and they actually brought to bear for us what we called elbow support. They brought about 2,000 individuals throughout the UNC system to Rocky Mount over those 30 days.
That's a significant effort.
It really was.
Yeah.
And for them to be able to be elbow to elbow with our nurses, our pharmacists, and our lab and imaging professionals, our physicians, to be able to help them through that learning curve. And so that's just an example of that. And then, of course, with the School of Medicine and our ability to find avenues for access for cardiology and working with cardiologists in the School of Medicine, those are just another example of how those assets come to bear for really the improvement of our local community.
Well, and I think there's a lot to be said for having the specialists and the care that we now have locally versus having to go out of town to get those services.
That's correct.
The state-of-the-art equipment that's at Nash UNC today, especially with Dr. Young and his environment over there, is actually more advanced than what you can get in Chapel Hill. And then that's a testament to what the partnership brings to Rocky Mount.
That's right. And I think it's important for the community and for the medical staff and individuals out in the audience to realize that at the end of the day, the investment is Nash, and the decision has to be the board of trustee or the board of commissioners, which is that 14 local members. Who make those decisions. And so I think that's important to keep in mind. I think it's important to remember that we have to make that financial investment, and we're the ones that vet that and make that decision.
So you've said the word financial and investment a few times now. So let's get into talking about a little bit about numbers a little bit. One of the things we talk about in today's environment. Today's environment is extremely complicated in the cost of healthcare, whether it's the patient side and they see all these weird insurance statements and settlement statements, or on your side in terms of operating a hospital where you're in the public space of getting repaid by so many different avenues and the regulations and the opportunities to recover some income. Let's talk about Nash UNC's kind of financial status today.
Sure. Well, when we sat down last year, we had just come off of our fiscal year 2018, which ended June. Each fiscal year ends June 30th, and so we had just come off that fiscal year. We had lost from operations $25 million. The board did not have the patience for that continued loss, and quite frankly, it wasn't the proper allocation of resources of the community's assets to continue that. So the board asked us to be quite aggressive in setting what we call a 2020 plan, which was really just a financial recovery plan over about a 5-year period to get us back to operational profitability. And so we have a target that for 2024 that will be back in the black from an operating standpoint. And this year, the board asked us to improve that losses by $11 million. So we were to go from a $25 million loss to about a $14 million loss, which only sounds good if you keep in mind that we had lost $25 million, right?
And a loss is a loss. So
that's
people
right.
still look at that as a loss, but it's still an improvement.
It is an improvement, and that was quite aggressive. I'm happy to tell you, although we haven't had the audited financials back, we have ended fiscal year 19, and that was the year we were supposed to make $11 million improvement. And so we will present the beginning of August, actually August 1st, to the Finance Committee and to the board that right now our estimates are that we'll have improved $17.5 million off of that.
That's a significant savings.
So it is a great deal of work. It really was achieved through the department leaders and the staff buying into what we were trying
Right.
to accomplish, and from the medical staff coming and supporting the hospital, and then from the community giving us an opportunity to earn back their business and their trust. And so,
Well, and it's not just that, and I want to make sure our viewers understand it's not just a matter of the cost of healthcare. It's also we live in a region that has a lot of impoverishment, that doesn't necessarily have the means to necessarily afford all their healthcare, but you can't refuse them, can you?
no, we are unable to. We have to treat everyone, and we have to do a medical screening. That's a little. Sometimes the public is confused by that. Quite frankly, sometimes we're confused by it.
Right.
And what that just simply means is that we have to ensure that the medical condition is no longer emergent, that
Right.
it is stable and can be treated either at our facility or by the primary care physician. Quite frankly, most hospitals like us, and we would agree with this, by the time we've done the medical screening, all the real resources have already been expended, and so we typically follow through with that
Right.
next treatment. And so because
But in most of those cases, you're absorbing all those
those
costs.
costs have already been absorbed, and the right thing to do is to continue to treat the patient.
Right.
And so we do that and continue
And
to move
that,
forward.
again, this is where you're kind of caught in a catch-22. So you have some patients out there who can't necessarily afford it, but you also are responsible for the complete follow-through of their care, which sometimes extends beyond just them walking out of the hospital and paying their first bill, so
That's
to say.
And I'm sorry, and that's really the importance of having the medical staff as a partner. And the board of commissioners takes it very seriously and embodies the mission of the hospital to take care of our community. And so they continue to remind and strive and push us to be able to do that.
Well, and again, statistically, it's one of those things you don't want to see revisits. You don't want somebody to have to come, in terms of, it's not recidivism, but essentially have to be rebedded in the hospital because of releasing them and not necessarily getting them completely well. Things happen, but I know that's one of those things where you get measured on that as well.
We do, and so obviously it's called readmission, and Medicare evaluates us. Other payers, such as Blue Cross Blue Shield, also evaluates us on our performance, and if we don't meet certain performance measures, will actually penalize us financially
Right.
For not meeting those measures.
One of the areas that has come up over the last few years has been the emergency room. What people, when they go to the ER room, they're not thinking of anybody else but themselves or the loved one that's in immediate distress. And so anytime they have to wait, suddenly just turns into, it's magnified because it's a less than great experience for them. How have you made it less worse for patients?
Well, certainly we've been working to make it a good experience and to make it an experience in which they feel cared for and knowledgeable about where their care is in the process, and just as important, where their family members' care is in the process. And so certainly there are lots of volumes and loads of volumes depending on the day and day of the week. And so as we've talked about, we're a very busy ER. We're on target for about 72,000 visits.
Wow. And you
this
draw
year.
that from what, about an 8-county region?
About 8-county region, and then we may have talked last year. I continue to be amazed that about 12,000 visits a year come from travelers coming up and down I-95. And so,
Wow. Yeah.
so they either have stopped in Rocky Mount or decide they can't make it any further than Rocky Mount.
Or they're playing ball at one of our parks
That's
and break
right.
a leg or something. And
All those things.
Yeah.
And so very busy. I believe last year we discussed that we had put a provider in triage. And so we were working on our door to provider time,
Right.
which we measure just as how long it takes an individual who comes through the front door to get to our provider. And we were beginning to see some really good results. The industry standard is less than 30 minutes.
Okay.
And we were last year beginning to see that. We have sustained that over this last year and actually are down to about 22 minutes on average
Wow.
for someone to see a provider. Now, again, I certainly have gotten feedback that says, well, yeah, I saw the provider, and then they just sent me back out into a sub-waiting, and I had to sit there. But the important part, and so it is incumbent upon us to let you know what's going on, and we need to do a better job with that. But probably most of the time, one of those things that are happening is that we've ordered labs, we've gotten other processes started, and
Right.
so it's not as if we've set you back to the queue and no activity.
You're back at the bottom of
That's
the line.
right. That's right.
Yeah.
And so we're making sure that happens, and we're seeing improvements on that. Our left without being seen is much improved. We're below 2%, which is the industry standard.
Right.
And so when we compare ourselves to the industry, we really are achieving and surpassing every industry standard with the exception of one, and we are keenly focused on that, and that's what we call the back-end time.
Okay.
So about 13% of all patients who come through the emergency department get admitted.
So they end up taking a bed.
They end up taking a bed in the hospital, and for those individuals, we've got to get you transitioned from the ER to the floor.
Right.
And we call that the back-end time, and that's the time you're waiting in the ER to get to the floor. And so one of the things, the industry standard is 333 minutes. And a year ago, we were at 575 minutes. So
that's a bit of a wait.
A lot of opportunity. We've been working with our emergency department physicians and our hospitalists. We're down to 430 minutes today. That's still 100 minutes. That's still an hour and a half from where we want to be. But one of the things we've been working with, I've been working with George Casarala, my chief operating officer and chief nursing officer has been working with the emergency department and with the hospitalist, and Dr. Casarala is the medical director for the hospitalist, and we just agreed this past month to add a second provider at night. So what we realized was the admissions at night was where we were having difficulty and where we were not able to achieve those numbers. And so we've added on another physician provider at night. That started this week. And so we'll continue to measure that. So we're committed to continuing to work on those numbers. And I think it's important. I think a lot of times when we talk, people think we only talk about the good things. So I want to make sure that we talk about the things that are still challenges for us. We recognize that, and we're working on it.
Well, that leads right into, and I don't know that you have a slide on this one specifically, but I know this one we talked about last year. I've talked to your predecessor about this, and this is kind of one of those things where you pay for this service to be measured against the industry. And that's the Leapfrog Report.
Yes.
And we talked about it extensively last time, so I'm not going to spend too much time on it, but I do think it's worthy to our audience to make sure they understand where it's coming from. The spring grade this year was a C, same as it was last year. So you didn't get worse. But the problem with that is it's kind of has a lag to it, does it not?
It
and you're also being very transparent in what you're reporting. And the same thing happened this year that happened last year. Where you're good, you're very good. And where you have some opportunities, you have some opportunities.
That's right.
One of them is especially around the intensive care unit. And y'all have made an active decision to do something different there. So how do you compensate for that in the report?
Sure. So there is a lag time. We knew the spring grade probably wasn't going to change, not just because of the lag time, but the things that they measure and how they measure it.
Right.
And so they don't collect as much new data in the spring as they do in the fall.
Right.
And so a couple of things that we've been working on diligently with a great deal of focus, and Ms. Jean Kitchen has been leading the Quality Leadership Council for the board and for the medical staff, and she has really focused us on making actions around the quality. And so we've seen dramatic decreases in our hospital-acquired infections or injuries. Those are the things that you acquire that you didn't have when you came in with us, but while you're staying with us, you acquire.
Yeah, right.
So certainly we want to eliminate those, and we really have seen dramatic decreases, about a 42% decrease over this last year, and a 50% decrease in our surgical site infections. And of course, our goal is to eliminate all of those.
Right. And I will say that's the stuff you hear about when you go to the Bojangles or something like that,
Sure.
and the people are talking around and saying, you get sick going to the hospital. You go in for one thing, you come out with another thing. y'all are aggressively working against reducing that and making it so that the patients don't have that much risk when they
And
come in.
we brought in the medical staff and we've put in best practices, protocols. Again, another opportunity for us to partner with UNC and garner their expertise, work with our medical staff. We have seen dramatic decreases because we standardize the way patients are taken through surgery. That has had a dramatic positive impact on reducing the surgical site infections. And so there are lags in the Leapfrog that probably won't show up until perhaps even not this fall, but next fall, that we should start seeing some improvements for the ICU you mentioned. And so one of the measures that Leapfrog measures us on is, do we have an intensivist 24 hours a day, 7 days a week? And so right now, Dr. Desai is working with us, and with the limited number of physicians we have, it's just impossible to have that covered 24/7, 365 in the manner in which Leapfrog measures hospitals on. We're no different than other hospitals our size. That doesn't stop us from being challenged to still meet that. And so Crystal Hayden, my Chief Operating Officer and Chief Nursing Officer, has been working with Sean Hartley, the Chief Financial Officer, Dr. Desai, and Dr. Casarala to identify some solutions. And so just actually yesterday, they sent over an analysis and a pro forma for me to review. We meet next week on where we would put what's called an electronic ICU, where we have physicians. They're just virtual or remotely located.
Well, in today's day and age, that's so much more feasible than it used to be.
And they're able to access Epic real time, see the record, make decisions. There would be a robot in which they could interface with the patient. They would be interfacing with the staff, and they would be helping us round on those patients. And so through that is a solution to be able to improve the care and the access, but also meet the Leapfrog criteria as well.
So that's an advance in telemedicine to an acute care situation that benefits our community, because you don't have to have the resources right here, right now, but you can access them right here, right now.
That's correct.
So let's talk real quick before we wrap things up a little bit. One of the things that's very important to the hospital is again, after the patient has left, what was their satisfaction? What was their how do they rate and judge the hospital? And I know that's something y'all worked very hard on with both the Joint Commission in terms of how y'all get measured against yourselves in the industry.
Sure.
But even for your own satisfaction, how are you treating your patients? How do they view you? How has the performance been getting better for the hospital lately?
Yeah, so I have probably been challenged with my patients on this. We have really put resource after resource after resource through rounding, of course, Carolina Care, which is our approach to patient experience, and the amount of leadership that our department leaders and staff have demonstrated. And we have seen some small improvements. Of course, there's 27 questions in the survey, and the one that we tend to get most focused on is rate the hospital from 0 to 10. And so that's kind of the litmus test for us on how we're doing. The national mean, or the 50th percentile, for that question is 72%. You want 72% of your patients to give you a 9 or a 10. Just refresh you and I and our community. An 8 is the same as a 0.
Why is that?
That's the Medicare's rules, and we have to keep in mind, although
because the patients don't know that.
That's correct. I mean,
that's part of the challenge is they might think, well, I don't give anybody a 10. So they're going to automatically downgrade just their nature. They go to a restaurant to do the same thing. They may have had the best service in the world, but they don't give anybody a perfect score. But you're still measured against it as if you should get one.
It is, and so I'm quite frustrated because I tell people when I'm out talking to them, I'm an 8 kind of guy. I like giving you 8 when I think you did a really good job, right? But we have to keep in mind that every hospital is treated the same. So every 8 across the country is still a 0.
Wow.
And so we have to keep that in mind, and we have to keep our focus on it. So a couple of things that I'm the most proud that the staff and the leadership there have put in place with the physician leadership is what we call first touch rounds and CAP rounds. And it's a team approach where we have the physician, nursing, the dietitian, the case management, the pharmacist, round as a team on the patient every day.
Gotcha.
And so what we have seen from that is we've seen small upticks in our hospital rating.
Right.
We've seen large rises in communication with physicians and communication with nurses. There's 3 questions about physician communication and 3 questions about nursing communication. Since we've put in these CAP rounds and first touch rounds, we've seen and been able to achieve for those 6 questions,
Right.
we've been able to achieve the 60th percentile and higher. So in some of those questions, we're in the upper quartile, so the top 75% of, or top 25% of hospitals across the country. And so
I'm glad you said that, because when you start saying quartile, our viewers are like, huh?
yeah, so the top 25% of hospitals across the country. And we know through research that those 6 questions highly influence the overall rating of
Right.
the hospital.
Now, are you getting more patients to fill them out? Because I know that has been a challenge in the past.
Sure. Well, we are continuing. Matter of fact, one of the things that we are adding soon is the ability, if the patient elects, for us to be able to remind them and for them to be able to communicate with us real time while they're in the hospital. We have added a laptop application. We call it Vocera.
Right.
And when I round, I can take that the iPad with me, and after I speak with a patient, if there are concerns, and whether it be dietary or housekeeping, I can alert dietary and housekeeping immediately that room or patient would like to speak with them or need some attention. And so those are things that we're putting in place this summer. So we continue to move forward.
And that's a hands-on approach. That's a nice personal touch to, again, sometimes what feels like a sterile environment.
Right. And so many of these things came out of the discussion through the strategic plan and through those first-year initiatives, where really at the end of the day, it's really about garnering our medical staff and bringing them back in with us through partnership, and making sure that we have a systematic approach of how to identify physician needs in the community, how we help recruit, and how we continue to work with our staff to promote the excellent care that they're providing. And at the end of the day, I want the community to know that it is always our intent to provide the very best care.
Right.
And we want to know the feedback, both good and bad. And I appreciate when I get a phone call that either gives me an opportunity or praises a staff member. And I always reach out to that staff member and let them know that a patient or a family member has appreciated the care that they have provided.
Well, and Lee, again, appreciate you coming in here today and talking to us. There's a lot of content and conversation. We haven't hit it all. Is there anything else you want to kind of focus on real quick while we wrap things up?
I think that just through our website, if our community would like to have more information on the strategic plan, it is available on the website. It is a transparent document. And so what I guess I'd like to leave our community with is that we want to be the very best and trusted healthcare provider.
Right.
And we're working towards that. And we want to hear your feedback. We're going to be honest and be transparent. And we're going to continue to improve and be a good steward of the resources that this community has provided us.
Well, Lee, we appreciate you coming in and making Nash UNC even better. It's a great facility. It's a great team of people who are working there, administrating and treating folks there. But, when it comes to healthcare, we want to be able to go to the closest place and the best place. Sometimes that don't always become the same thing in other communities. It's nice to have that in Rocky Mountain where the closest place is the best place.
And we certainly believe that and certainly are striving to make that true. Thank you very much.
All right. Well, Dr. Lee Isley with Nash UNC Healthcare has been with us today, and we very much appreciate you coming in and being honest and transparent about what's going on with the hospital.
Thank you, sir.
All right, we'll be right back.